Hey, well, welcome everybody. I am really delighted to have the privilege of welcoming people to today's seminar for the Lee Kum-Sheng Center for Health and Happiness. We are welcoming Dr. Jennifer Prah Ruger, who is the Amartya Professor of Health Equity, Economics, and Policy at the University of Pennsylvania. She is a leading scholar of global and domestic health policy and public health. Her theoretical and empirical studies address equity among women and children. She directs the Health Equity and Policy Lab at the University of Pennsylvania, which studies health policy and public health problems related to equity and efficiency of health system access, financing, resource allocation, policy reform, and the social determinants of health. I think that's probably enough to keep her busy for a while. She's received numerous awards and accolades, including a Guggenheim Fellowship, a Greenwall Faculty Scholar Award in Bioethics. We did just hear she's starting a new RWJ funded project. So if there's a minute to hear about that, we'd be curious to hear. We're just delighted to have her here. And one of the things I think is so interesting about her work is that she has a lens that thinks not only about deficits, but also about assets and resources and how to help people attain health through the use of those kinds of resources as well. So with that, she's going to discuss the health capability profile today and its application in an empirical study of chronic hepatitis B in Senegal, I believe. So with that, I'm going to turn it over to you. Thank you, Dr. Prah Ruger.
Well, thank you, Laura and Vish, for inviting me, and for everyone who has, Jamie and Malia have been working on this behind the scenes. So I'm delighted to be here and just think there's so much overlap in common interests between our work and yours. So this is terrific. All right, so I'm gonna share my screen because I have a PowerPoint to go through with you all.
And sorry, while you're sharing your screen, one thing I just forgot to mention is if folks have questions, please feel free to put them in the chat. I'll collect the questions and then relay them at the end of the presentation so we can have a little bit of discussion and Q&A. So thanks.
Okay, great. So I'm discussing applying the health capability profile. This is a joint project with my collaborators are there listed, and one particular collaborator actually is on the Zoom, Marianne, so she may jump in, particularly in the Q&A. We have some more specific questions related to the HPV context in particular. So by way of outline, we're going to talk first about the health capability model and profile, why the health capability profile. We'll try to move as expeditiously through that as possible. Then an empirical study that we're currently working on chronic hepatitis B in rural Senegal, basically how we empirically study the health capability profile. And then we should get to maybe one or maybe two hypothetical case studies. And this is sort of demonstrating how the health capability profile actually works. All right, so the health capability model and profile, sort of why are we interested in this? So health capability is a concept that I've been working on for a while now. It's the ability or power to perform with the potential for achieve desired ends. It entails an aptitude. So it's on the positive side of the health spectrum. It's a cradle to grave concept. It requires lifelong abilities and conditions that enable optimal health. And so health capabilities are key strengths, and they result from individual and societal commitments. And that's key, individual and societal commitments of human, financial, physical resources with the goal of helping people to thrive. Differences in health capabilities help us understand why personal skills and determination alone or just health beliefs are not enough, why even people with the best external conditions can still have poor health, and why a narrow biomedical model of disease is insufficient. This is the health capability model. Let me preface this by saying that a lot of this material can be found on our website, the Health Equity and Policy Lab website, HEPL. So I'll go through some of this in a cursory fashion, but you can certainly look more deeply into it there. This is the health capability model. Health capability captures, it's a dynamic and interactive multidimensionality of health and flourishing. So where the circles overlap, we have a biological and genetic predisposition, we have our intermediate social context, we have the public health and healthcare system, and then we have our macro social, political, and economic environment. And sort of where the circles overlap, this figure represents the way individual and societal factors interact to create health capability, which is the confidence and ability to be effective in achieving optimal health given one's own biological and genetic disposition, intermediate and broader social, political, and economic environment, and then access to, hopefully, at the optimal end, an enabling public health system and a healthcare system. So health capability model is can be thought about in conjunction with other models. More linear models are limited. They tend to be limited in one-to-one associations among variables. So even with interactive terms or even with controls, they have this kind of a linear sense to them. They're reductionist. And they look primarily at simple relationships and then some principal subcomponents. So these are aggregated forms which have a tendency to be difficult to interpret. We're talking more about interaction and dynamism here. Health capability, the model we believe is more flexible and analytical. It accounts for both internal and external influences at the individual level. And so it allows for contemporaneous multiple relationships among factors. And so the overlapping feature is a nuanced, sequentially interactive, iterative, dynamic, and multidimensional understanding. So this model reveals a heterogeneity that we believe exists in real life of irreducibly social goods and experiences on the individual, and then the individual's influence on society. So that's what we're trying to get at in this model. We think some of the strengths are that it's effective for a longitudinal sense, intersectoral, multisectoral policy, and institutional analysis and design over time. Again, we said it's a cradle to grave idea. It allows more for heterogeneity in relations among individual and societal factors. So for example, the difference between race as a variable, as we just said in the current models or prior models, versus racism, and how that experience affects people individually and societally. Again, instead of sex or gender, we're looking at sexism or heteronormativity and trying to understand that. We're trying to get at capability capital. How do you build a capital in people's capabilities and societal capabilities? And so we're trying to incorporate external factors at the individual level. The health capability profile is the operationalization of the health capability model. And again, this is just, I'll go over this really briefly because it's on our website. The health capability profile comprises 15 different health capabilities, and that encompasses 49 separate health functionings and health agencies. The profile takes a snapshot and tracks health capabilities development. And the goal is for each and every person to reach their highest health potential, their full health capability. So we believe this provides a fuller picture or a full picture of a person's lived experience and their journey in reaching their health and flourishing potential. This is from our website. This is also on our website. These capability numbers and domains, and then these are the 15 types of internal capabilities and external capabilities. Again, I'm not going to go into that in detail because we've got so much to cover today. But this is on our website, and this is also on our website just to give you an idea. I'm not going to go into this in detail. An internal capability of, for example, health, valuing health. This is the value of health. And this is important in and of itself, in addition to health functioning. So do people value health-related goals? Do they value lifestyle choices? Do they value their health? And we go through, and again, I'll refer you to the website. Why is valuing health important? What does it look like? and how do I do it? I, meaning this is an internal capability. And then we have our external capabilities. Here's just one example. Again, I'll refer you to the website. Social norms, for example, is an external capability. This is cultures of health and expected behaviors in a society. To the, things like the extent to which health norms are scientifically valid and evidence-based, whether health behaviors and health seeking skills are viewed favorably or unfavorably, whether their health behaviors are adopted by a majority or minority of the population, etc. Again, on our website, we go through each one of the 15 internal and external capabilities, why it's important, what does it look like, and here we say, how do we do it, because it's an external capability that society is focused on. All right, so I've gone over a lot of this. Let me just quickly say again, in terms of strengths, we believe it's a more flexible, detailed, multidimensional topology, dynamic framework. It focuses very much in the realm of implementation sciences. So the why? Because we're looking at identifying gaps between what's observed in terms of health capabilities and the optimal level of health capability. So what's possible? In other words, what's possible anywhere should be possible everywhere. And it has a normative dimension. Following the health capability paradigm, which is the theory of social health and social justice that was advanced in health and social justice, which was a book that was written actually now many years ago. Okay, so in terms of applying the health capability profile, these are the steps that we're going to take you through in this presentation. The first is adapting the profile to a particular health condition and a particular setting, and that's what we'll be showing you today. The methods used, and we're advancing a mixed methods approach that has a social justice orientation at its roots. It's a mixed methods approach where we have quantitative and qualitative data collection, and then we integrate the data on a scale from 0 to 100, and we'll walk you through what that looks like, as well as flow diagrams to try to get to understand the dynamic nature that I was just talking about in terms of health capability development. And then hopefully this leads, ultimately towards policy change for health capability for all people. All right, so our empirical study is of chronic hepatitis B virus infection in rural Senegal. And this is sort of helping us understand how we empirically study the health capability profile. And we look at a problem that is still massive, 800,000 annual deaths, secondary to chronic hepatitis B virus infection worldwide. And it's a problem, it's a very good problem here to be looking at because HBV-related morbidity mortality is avoidable. And even the WHO strategy on viral hepatitis calls for its elimination completely by 2030. And there are 3 pillars to the strategy: prevention, testing, and treatment. In terms of prevention of HBV infection, this relies on vaccination, and this is readily available now. There are 3 dose. It's a 3-dose schedule, and so this is something that is possible in terms of elimination. Testing is key to identifying people who are chronically infected with HBV. This is because HBV infection actually is often asymptomatic, especially in its early stages. And then treatment is important for the lifelong linkage to care because it's a chronic disease. There's no cure. And so complications can occur from the infection, such as liver damage, cirrhosis, even liver cancer. And lifelong antiviral therapies can help avoid this kind of morbidity and even mortality. Yet there are major gaps in HBV care. This is just the WHO data looking at where we are in terms of testing and where we are in terms of treatment. Big gaps there. So chronic HBV and viral hepatitis programs are very important at the systematic level. And in Senegal, we've seen development of the program. It's a very important and interesting area to be studying. HPV prevalence is the highest in the Western Pacific region and in Africa. And Senegal was actually the first sub-Saharan African country to set up a viral hepatitis program in 1999. And then the HPV vaccination with the 3 doses was introduced in 2004, but there's been a upping of the program, and it's been improved in terms of completion of the vaccination with a birth dose since about 2016. So there's actually been a lot of effort by the Ministry of Health, and they've actually decentralized HPV care, and that's fairly recently. So in terms of our partners and thinking about, wanting to study this in this context with this particular model, they really thought that this was a very good time to do that. And yet HPV testing and care, two of the 3 parts of the program is costly and scarcely available, specifically in rural areas. And about 10% of the Senegalese population lives with chronic HPV infection. It's a major problem, major issue. Our study setting is in the Niakhar Health and Demographic Survey System, and it's a rural area of particular interest because of the high rates of HPV, and it also was hosting the first sub-Saharan African HPV vaccine trials. So there's a strong history, and it's also a pilot region for this decentralization of HPV care from the Ministry of Health. Now, there's already been really excellent work being done in HPV testing in the general population currently, and we'll talk about how our study is in collaboration with the AMBA survey that's already being done on the burden of chronic hepatitis B infection. That's recruited over 3,000 participants between 2018 and 2019. Okay, look at time here. Okay, so the objectives of this study are to study HPV morbidity and mortality using the health capability profile. And our research questions look at the gaps between observed and optimal health capabilities relevant to HPV in this setting. Are there vulnerabilities that are peculiar to chronic HPV patients, in particular in relation to entry into HPV care? So this is the testing and the treatment side of things. What can we learn from positive examples of highly developed health capability profiles in this context? And how can we inform and prioritize short and long-term policy and behavior change and move that forward in terms of this information? In terms of research methodology, we're really interested in applying this mixed methods approach. And again, we look forward to some feedback on how that's going from your perspective. All right, so adapting the profile to chronic hepatitis B in Senegal. Basically, what we've done is we've looked at, this is just, what we're doing is we're looking at the adaptation for transmission routes, risk factors, prevention, testing, vaccination, follow-up, and treatment. We're looking at the external factors in terms of social norms, social capital, material circumstances, and we're also at the national level, also and at the local level, we're attempting to work collaboratively in terms of the stakeholders involved in the care and the programs, particularly at the pilot stage. So here's an illustration of how we've been adapting the profile. And again, in the Q&A, look forward to your feedback. So as I said, there are the 15 different internal and external health capabilities. And so we're adapting it to HPV-related illness and risk in rural Senegal. And so the first couple internal health capabilities are health status and health functioning, health knowledge, and health seeking skills and beliefs and self-efficacy. And so basically how we've adapted this is we've looked to try to develop questions or employ existing questions that help us to understand individual status with respect to these capabilities. So, HPV status, their disease evolution, whether people have been vaccinated, the risk factors. Alcohol use and obesity are major risk factors for this condition. We're trying to get a better sense of people's, not just people's general health knowledge, but people's specific knowledge, for example, of their own hepatitis B and HBV vaccination status, of HBV transmission routes, the disease evolution, whether people know about testing or treatment, how much they know about HBV risk factors, and how much they know about getting information. And so improving in their knowledge and what sources of information are more valid than others. In terms of health seeking skills and beliefs, we're interested in trying to understand how solid people's beliefs are in their ability to avoid the infection, avoid transmission, or avoid complications, and how they feel about their ability to acquire HBV related skills, learning how to monitor their condition should they have it, and avoid infection or transmission. And then their confidence in their ability to perform or abstain from particular behaviors that put them at risk. Other internal health capabilities include health values and goals, self-governance and self-management, and perceived self-governance and management, effective health decision-making, intrinsic motivation, and positive expectations. And there's a lot here, so I'll just go over a few examples of the questions, the kinds of questions that we're asking in these different internal health capability domains. So how much do they value the prevention of HBV infection? How much do they value the different lifestyles or behaviors? And how do they feel about their ability to control their own life? How do they feel about their ability to control their own behaviors related to HBV related purposes? And for example, avoiding situations that involve alcohol, it's a major risk factor here for complications, and their ability to seek out support in terms of accessing testing, vaccination, or treatment. How about how they feel about their abilities in terms of decision-making, how to use health-related knowledge to avoid infection, transmission, or disease evolution. Again, disease evolution is a big one because that's where we see major complications. So understanding even at that stage how to use knowledge and information to intervene is important. And then the ability to identify symptoms and pursue treatment, vaccination, or testing. People's trying to get a sense of their internal or intrinsic motivation to avoid infection, transmission, and complications, and whether they have a positive or optimistic or pessimistic viewpoint with respect to this condition. Let me just go through, let me see where we are on time. I gotta move through more quickly here. So these are external, these are some of the external health capabilities that we're quantifying and measuring. Social norms, social networks, and social capital for achieving positive health outcomes, group membership influences, and material circumstances. So, we really think that social norms are critical in people's ability to be healthy. So what are the norms about Hep B, and what are their favorable or unfavorable views on vaccinations, on people living with HBV, on alcohol and condom use, and is there a sense of discrimination or bias with respect to people living with HBV? Are people even seeking to access vaccination or treatment? Norms about decisional latitude or power, and whether people actually have the ability to seek out vaccination, testing, or treatment, and sort of how that's operating or governing people's behavior. How people are using their social networks for instrumental help, whether there are patients associations or different groups and networks around in relation to HBV that people can access as social networks. Or whether there are social networks that are having a detrimental impact in relation to HBV, sharing of false information, for example. And then we're looking at material circumstances as well, and how that relates to their abilities. And then lastly, the broader economic, political, and social security. These are, again, external health capabilities, utilization and access to health services, and whether or not there's an enabling public health and healthcare system. So let me just take the last two, where we're talking about whether or not when people have symptoms, for example, jaundice, are they going out and able to get care? Do they have perception of the need to even see a healthcare provider? Or is a traditional medical provider the first choice? What is the existence of HPV-related health services and the availability of vaccination testing and follow-up exams? And what are the barriers? Is there geographic inaccessibility? Is it time? Is it cost? What's going on here? And then what is going on at the system level? This is what we said, bringing in the stakeholders in the study, in terms of ministry representatives, physicians, regional hospitals. What are they doing? Are they giving information to people? Are they helping people take charge of prevention? Are they protecting people from infection and transmission? Are they being efficient in providing care? And are they being accountable? So trying to get a better sense of what's going on there at the system level. Okay, so in terms of methods, we're employing a social justice mixed methods approach. And I mentioned that a little bit earlier, so I won't go into that in great detail, but basically it's the health capability paradigm, which is, essentially saying that, everyone should have the internal and external capabilities developed to the point, and we'll show you what that looks like on our scale, essentially mastery, to be able to prevent, and then that will, in the long run, that will lead towards elimination, but then, test and treat currently people who are at risk or are suffering, and reduce that disease progression, so that every person should have that ability, and that the shortfall inequality, which means the difference between what's possible and the highly capable people or individuals and where some people are, is to be reduced. That's a matter of equity and justice, and that really does drive the orientation of our study. We're also looking, again, we mentioned stakeholders are involved and being assessed. We're asking questions, and then we're looking for data both on objective situations as well as subjective experiences. We're using an explanatory core design. Our quantitative survey provides an overview and is used for then purposeful sampling of individuals to interview. So our data collection is conducted at the individual level. So the quantitative survey looks at gaps in HPV status, vaccination, et cetera. And then our qualitative interviews are selected because people are representing the population, and they're also at each end of this health capability profile. So we want to see people who are highly developed in their various health capabilities, and then where there's a lot of room for development. We're employing convergent core design, where we collect additional information on external health capabilities using focus groups and health facility survey. This is, again, where we're bringing in the stakeholders, and the data collected at the group or the community level for this part of the data collection. Our qualitative and quantitative data are then integrated to document the HPV related health capability profile of people. All right, so our quantitative survey, we're using the data from the AMBA survey, let me move through as expeditiously as possible. So when we get to the Q&A, if you have further questions, and Marianne is also on the Zoom, so she can help with some specifics about this survey. We have 300 households in Niakar HDSS where they were randomly selected. Participants in the study involved HPV testing. So they had the dried blood spot and face-to-face questionnaire, their dried blood spot testing, and then the face-to-face questionnaires as well. And in the second step, our HPV plus participants undertook further exams to assess then the stage of their disease. Treatment was then provided for free to those who were eligible. Here's some data from the quantitative survey, and we can come back to this later, but it's more or less some of the things that I was talking about earlier with the internal and external capabilities. The semi-structured interviews with the AMBAS participants we're planning. So we've sort of been interrupted with COVID, so we're not there yet. We've developed the interview guide and drafted, and we've adapted it and translated it. We have we've done the purposeful sampling, and so we have the populations that we're looking for. And we're basically going to be conducting the interviews in the upcoming months. So our interview guide, here's an example of it. So for example, this is more specific to what I was talking about internal capability of health knowledge. So these are the categories of health knowledge that we're looking at in the blue rectangle, and in the green sort of vertical rectangle, and in the green horizontal rectangle are some of the actual specific questions. So this is asking people whether they know that if they have Hep B, if they know what it is, if they know how people get it, do they know if it's possible to prevent getting it or giving it to somebody else? Do they know what they're supposed to do or what they're not supposed to do? Do they know the evolution of the disease, that it moves from acute to chronic infection, and that there are complications that can be very serious all the way to liver disease and liver cancer? Do people know about the risk factors and that they can accelerate the disease evolution in some people? And do they know what they are? Do they know what one should do if somebody gets chronic hepatitis B infection, and what annual biannual exams are and entail in terms of assessing the stage of disease, et cetera. Do they know how to get credible information about health and where they get it, where they get information about Hep B? And so these are the more granular sort of questions that we're asking people in the interview guide. Our data analysis plan is multi-layered. The first layer is to go through the individual level by documenting the individual health capability profiles. And then our data integration strategy is we're going to adopt a position of equal value for the quantitative and the qualitative data. And we'll be producing quantitative results, qualitative results, and a mixed method result. We're going to show you in a minute what that's going to look like. And then our mixed methods analysis, we're developing a 0 to 100 health capability score, and we're developing flow diagrams at the individual level. We're going to show you just some examples of that because as you see, we're in the middle of the study, so we don't have our results yet. Our synergistic approach to our data analysis, again, is we have our quantitative data that we've already developed. We've already gathered through the AMBAS survey, and we have that information. And now we have our purposeful sample that we're working on for those 40 to 50 interviews. And so that quantitative data can help us identify the gaps in health capabilities that are there. And then we can look at the shortfalls from the optimas over the whole profile. And then the qualitative data can help us look at the interaction between the health capabilities, those 15 internal and external health capabilities. All right, so what does this look like? So our scoring is going to be from 0 to 100, as I said before. And so 100 is a maximal score, an optimal level. It corresponds to a normative. It's what we want, what we think we should have. That's the social justice orientation behind it, is that's where we think people should be, if they can be. Again, it's their health potential. But it's a realistic and attainable goal, because what's possible anywhere should be possible everywhere. So we've created this indicative scoring guide in terms of the stages of capability development. So 0 is no capability there, it's absent or non-existent. 10 to 25 are 2 basic levels of capability development. 40 to up to 70 are intermediate levels, and we are really trying to get different categories so that we're trying to understand stages of development, again, in this much more dynamic way, as opposed to just giving a point estimate along 0 to 100. Then people are at more advanced levels, advanced 1 and 2 in the 70 to up to 100 range, and then 100 is more optimal. So what does that look like for the internal capabilities, and what does it look like for the external capabilities? So the internal capabilities are what the individual is able to do. And the external capabilities are what conditions society is creating or enabling for a person to do things. So an internal capability is at the non-developed level is at the naive or novice level. Then moving up the spectrum from 20, and we're attaching the range 25 to 40 to an advanced beginner. 40 is someone who's becoming pretty autonomous in developing this capability. 55, they're becoming competent. 70, they're becoming more experienced. 85, they're becoming proficient. And then optimally, they're an expert in that particular internal capability, or what we might say mastery. So that's where we are there. And then in external capabilities, is the society creating the conditions? If not at all, it's unpropitious. Non-hindering is sort of the next stage. Then there's more promising conditions, and then there's propitious, and then there's favorable, and then there's facilitating, enabling, and then fully enabling. That's when the conditions are really fully enabling a person to be healthy. Here we're talking about a person to prevent HPV infection through vaccination, to get tested and then obtain treatment, to reduce the onset of that severity progression in the disease. There is no cure, to be able to have a long-term treatment plan. Okay. So our analysis and expected results are going to be the flow diagrams, and I'm going to walk you through maybe one at the end, and then 0 to 100 health capability scores. And we believe these are tools, not like results. And the reason is, I mean, they tell us something. They're there for a reason. They help us integrate the quantitative and qualitative data as part of the profile. And they're really just trying to help us understand where people are, where society is, and where it needs to go in terms of developing these capabilities. And when we're asking people about them, we'll have the answers, which comes from them and their experiences, individuals, but also the stakeholders who are the experts in areas too. So the profile as a whole is what creates the health capability, and the goal again is for everyone to reach his or her or their potential. Let me just go through very, very quickly a hypothetical case study, and this helps us understand how the flow diagrams work in terms of understanding our analysis and presenting what we find. How does the health capability profile work? So here's a hypothetical case study of a person, Kay. Kay's pregnant. She lives an hour walk from the nearest health dispensary. Her family doesn't have means of transportation. Her friends at the market and the wife of the head of her household all told her she needs to attend the 4 prenatal visits at the dispensary. One of her neighbors offers to take her to the dispensary with the motorbike, but Kay first has to get her head of household's approval, as well as his mother's, and had to push back her first visit several times. During the visit, the nurse mentions that she could do hepatitis B testing as part of her follow-up, but it costs $3 US, and she has to go to the regional hospital 15 kilometers away. Kay doesn't know what Hep B is and doesn't investigate further. So this is an interactive flow diagram that helps us try to identify the key parts of the health capability profile that are at work in this particular case study. Okay, so it's not going to show you all of the different internal and external health capabilities. It identifies the key ones that are at work. So Kay lives far from the healthcare dispensary and has no transportation. Those are her material circumstances. Her friends told her to attend prenatal visits, so she's got strong group membership that's moving in the positive direction of health capability development. A neighbor offers to drive her, so there's social capital and networks working in her favor there. All pregnant women attend prenatal visits, but they need to ask for permission. So these are the social norms that are operating and sort of working in this case. Kay eventually does attend the prenatal visit. So that's a good sign in terms of healthcare access and utilization coming from the help from the social capital networks that are involved in Kay's life, and coming from the group membership of being involved with people who are telling her to attend prenatal visits, also coming from the social norms in which pregnant women tend to attend prenatal visits. But they have to get permission, so that's on the deficit side, which reduces her agency, her health agency, which is part of the health capability. And living far away and not having transportation also reduces her capability there. But she doesn't undertake the HBV testing. She doesn't know about it. She doesn't have that information. She doesn't know what it is. And so the healthcare system is her knowledge is not at the level that, those levels that we talked about, is not at the level where it's an enabling experience. And she's able to use her knowledge to use healthcare. And there's no hepatitis B counseling or agency building. The infant is not fully protected from HBV transmission. So we're not seeing the enabling health system. So we have a couple other, I'm just going to go through this. We have two other, but I think we'll stop after this and we'll go to Q&A. How can we develop case health capabilities? So these are again the key parts: better training of healthcare professionals on Hep B counseling so that complete information is delivered as part of the prenatal visits. This would help Kay reduce her shortfall in knowledge and her shortfall in enabling healthcare systems. Hep B rapid tests are available at the local dispensary and for free. This would help improve Kay's health service access and utilization, and strengthening women's empowerment through changes in social norms relating to her decisional latitude would also improve her health capability. So I think I should stop there. We have a couple more slides, but I think I should stop sharing my screen and open it up for questions. Thank you for your patience and attention.
Well, thank you. That was just incredibly rich and exciting. And I'm sure we're not going to have enough time to talk about all the questions that we have. But why don't we, people can put things in chat if they have questions. And I don't know if anyone wants to start. Vish, I was looking at you, Vish. I was like, I know Vish is going to have questions. So let's start with Vish.
I'm just trying to help you, Lara.
I know, I appreciate that.
Right. So Jennifer, that was wonderful. That was, as we call it, tour de force, so really very rich, as Lara said, a very nice framework. I have many questions, but in the interest of time, I will ask one, and then if there is time, I can ask others later. So you have the 15 dimensions or 15 different capabilities. How did you decide these are the 15 and not others? For example, I might have missed it, not social support. I'm just throwing it as an illustration. How did you come up with this list of 15?
Thank you, Vish. That's a great question. Social support is included. I glossed over it. It was quick. Yeah, so it was a massive and thorough review of the literature, both theoretical and empirical, over many, many, many years. And really trying to, from a theoretical perspective, and again, steeped in social justice, which is we're trying to understand, right, what optimal health is, how to reach people's potential. And so if we're starting from that perspective, then we're seeing things that some of the other models aren't seeing or just aren't capturing because that wasn't there. I mean, a lot of this is in social epidemiology, as you know, right? The social determinants of health or health psychology at the individual level, right? And some of these are, we do cite some of the prior work, of course, in the development of the health capability profile. Absolutely. Building on the shoulders of this great work in health psychology, primarily focused on the individual level. There's some social psychology, but not as much in health. And then the great work in social epidemiology, wonderful work, and on the social determinants of health. Fantastic. However, we just really didn't think that where things were in that literature and that empirical work, even up to the empirical work, and people at Harvard have been doing. I mean, there's so many great people doing great work, but just really felt like it was missing. And I think one of the reasons that we were able to see it was illuminated in that way is because we were looking at it from a social justice perspective. What's missing? What are we really after? We're really after flourishing. We're really after people's ability to do and be what they want to do and be. And then health capability, which I developed really when I was there as a graduate student, is about the ability to be healthy. And it includes people's agency, which isn't a part of, except for the health psychology, the individual self-efficacy and things like that, but also their functioning. And it includes their internal abilities as they relate to the external ones. So that's how it's been developing. And I'm always, when I talk and get feedback in the literature too, always looking for feedback on things that we may use to improve it. Thank you.
That's great, thanks. We do have another question from Mesfin. And Mesfin, I'm gonna let you ask your own question since we're small anyway. So if you want to just unmute yourself, you can go ahead.
Okay, yeah, thank you. My question is, I mean, I may have missed it, but the case that you showed us it's related to an individual case. So I was wondering if this model can also be applied to profile groups of people. I mean, from a disparity, from an equity perspective. Thank you.
Thank you. Excellent question. Yes, but it's not a simple aggregation. That's the thing. And we're not just adding up numbers. We're trying to synergistically, as we mentioned in our analytical plan, synergistically analyze these health capability profiles, and then try to aggregate sort of the word, but sort of bring together the lessons from these various people. Now, remember, for the qualitative work, we only have 40 or 50 people. It's a smaller sample size. So we'll learn as we go how the synergistic approach and triangulation works, and what we're able to see both at the individual level, but yes, at the group level too. So thank you so much. The issue is, the reason we're not straight aggregating is because there's so much heterogeneity and richness, right, at the individual level. That's why we're showing these, and we had two other flow diagrams I didn't show you, but they're all different, and there were just three. So, it's just going to be really interesting to look at these and try to then understand what the patterns are, right, at the group level to the extent we can. But we're also have so much richness in the profile, we think, at the individual level too. So it's both. Thank you.
Thank you. Yeah.
Okay, well, I'm going to take the moderator's prerogative and have a question too. I have two kind of nerd questions that are related. And one is sort of, when you're deciding how to explain a case study and you're assigning elements of the model to elements of the story, is that something that you have to do with like inter-rater reliability, or there's just some kind of, the model well enough that anybody who works with the model long enough is confident they can assign those those capabilities to those aspects of the story that you're taking from the case study. So that's one question. And I think a related question is, have you done any evaluation of the health capability model recommendations, right? So you guys come up with a set of recommendations where you say, okay, these people are, at a 55, right? And so now here's what we're going to recommend to get them to, maybe a 75 or something. And then is there any way to evaluate the effectiveness of those recommendations, or is it too hard because you're reliant on so many other things happening once the recommendations get made? It's kind of about testing the model, really.
Thank you. This is great. Yes. So what I showed you was those were hypothetical, and we had 2 more hypotheticals. So that's sort of where we're going and where we look at it. But yes, there'll be 2 people. But it is, you put your finger on it. It really is important that the people are well trained in the health capability model. It's not just dropping somebody from the outside right in. And we're actually doing an application right now in heart failure, similar with the health capability profile and applying it. And it's 2 people who've been trained in the model and understanding it and trying to, put these put the health capability dimension in the scoring, system, which is really challenging, but I'm sort of excited about the scoring we're cutting. That took a really long time to come up with, which really hard to figure out how to do this kind of a scale and have provide more information as to where people are and that there's a development going on here. And it's not just a number out of context. So, and we'll see. So that's relates to your second question is we don't know. No, we have not evaluated. We really haven't done very much empirical work. And so we'll just see, and it'll be good to get feedback and of course, responsibly, how's this working or not, and what can we do better? So thank you.
That's great. Thanks. That's really interesting. I think there'll be so many interesting ways to try to, measure how it's going, and yeah, lots to talk about. I know Vish has another question, and since other people haven't jumped in yet, I'll give it back to Vish.
Thank you, Lara. Please jump in others. I'm asking, I have 10,000 questions, so I can keep asking for the rest of the day. But you answered, you began answering this question actually, Jennifer, when Laura asked that profile question. So I'm trying to understand here. There is something called psychographic segmentation approaches, right? This notion of, one of them is called values and lifestyle. So they create these, a combination of demographic, sociological, geographic, and psychological variables to create these profiles. I think Mesfin was also trying to ask this earlier on. And then these profiles are very useful in developing appropriate intervention strategies, both in terms of messages one can construct, as well as channels one can use to promote X, Y, or Z. Mostly used in marketing to sell products, though there is value in doing it for health behaviors too. So I was wondering as I was thinking about it, but yours is much more complicated. It's not that simplistic as some of the marketing ones are. But this notion of recommendations that Lara was asking. So if I were to do interventions to increase that capability, where would I focus on? Is it on social norms, or is it on healthcare utilization? Because generally we can't do everything, right? So you have to weigh some more than others. Is it contextual? Maybe I don't know whether I'm making sense of that.
You're making complete sense. But what we're saying is you need to look at all the factors that these efforts. So I guess what I would say is it's the counterfactual. So this is why we have a social justice lens. There is no excuse. There is no excuse for certain conditions not to have been eliminated in every context in the world where it is possible to eliminate them somewhere. I've also recently done a study on fistula. It is not acceptable that fistula is still a major problem for many women in the world. It is completely 100% preventable. This is another preventable disease and disease progression. And so we need to start looking at where we're spending money. I was trained as a health economist. I'm a social scientist. I am absolutely aware of economics and cost effectiveness and the need to look at where we prioritize our resource allocation. And I think we have to look at the counterfactual. What have we been doing? Where have we been spending our money? And has that really been the most efficient way? Is it the most efficient way to pick one thing or one part of a problem and to, put a lot, that's why we're trying to find the key areas. So when I showed you the flow chart, it's not going to be everything, right? It's what are the key areas here that are working well to build on, right? And it may not need as much investment in that particular person or group, but certainly could be expanded because they work really well. And then areas that are major deficits. So I think it's really trying to get a holistic picture of the problem and understand it. And it's also saying, again, this has been done other places. Right. I mean, and this is why it has not been, completely eradicated or eliminated here. These are what and I think, there's the other sort of, next frontier of economics, right? And saying, scarcity has always been a major issue, and opportunity cost is an absolutely important economic principle, but are we solving some scarcity issues, with technology, and expanding the frontier? In some ways we have. Look, we can transfer data across through the air, from, North America to Africa. Let's just look at where we're spending our money, right? So it's an excellent question. But I think we need to really look at in the broader societal prioritization and resource allocation framework.
Thank you.
So I know we're just about out of time, but let's see if we can squeeze one last question. We've got someone who said, could you say more about changing cultural norms of alcohol, how it impairs both social justice and Hep B treatment? And then I know folks might have to go, feel free to drop off, but we'll just see if we can squeeze this last one in. So good, such a good question. Thank you so much. This is such a key area. There's a lot there. How do you change social norms about alcohol and drug use? First of all, I'm not a communications person. I mean, Vish probably has, Laura probably have better ideas about this than I do about the actual changing of the norms. But what I can say is we are becoming more and more knowledgeable about the changes in our brain that occur from the use of alcohol and drugs, and the time at which we change our brain, the age at which there's onset of use, the context. We do understand that social pressure is our brains are hardwired to be more influenced by our peers when we're in the most vulnerable stages of our lives with respect to drug and alcohol use. So it's all to say we have a lot more information now about alcohol and drug use that can be helpful in terms of trying to figure out how to then change norms about our behaviors related to it. I think there's just been a lot more, you look at even in the United States. I mean, there's a lot of misinformation, and we now know a lot more. So I think hopefully we could do more, but I defer to your two center directors here for that one. Well, thank you so much. This is so great. And of course, I can't resist saying how I can only imagine that applying this kind of model to the whole COVID-19 circumstances seems incredibly like it will be very timely and useful. So we'll look forward. I can only imagine that you guys are thinking about that. So thank you so much for your time. We will probably follow up with some of our own questions. We've got lots of areas, as you said, of synergistic interest. So we'll probably follow up on that. And in the meantime, I want to say thanks to everyone else who joined us. Our next seminar is actually Wednesday, May 19th, and we have Dr. Carol Graham, who will be joining us. She's the Leo Pasvolsky Senior Fellow at the Brookings Institute, as well as a professor at the University of Maryland and a senior scientist at Gallup. And she's done a lot of work on the study of poverty, inequality, subjective well-being, economics of happiness. So she'll have a lot of interesting things to say as well, I think particularly about the measurement of well-being. So we'll hopefully see lots of folks at the next seminar as well. And of course, Jennifer, you're welcome to join us for that too. All right, thanks all, I appreciate your coming.
Thank you.